As far as we are concerned in ISI, we are not having any Indian standard laid down for the sport gears. However, some of the standards are laid down for the material being used for the protective gears. And on liquors, safety also is of utmost important, and for that matter we must know the area where we are going to and we are passing by, and the area what games are being played too. And these are the recommendations. Again, I would not like to repeat. Sports venue responsibilities also must be considered as a part of responsibility, as a part of compensation when a person receives an injury due to sports. Thank you very much.
Thank you, sir. Basic talk. We all know the importance of history taking. Spoken at length about that. In addition to a penetrating injury, we have blunt trauma. In addition, the blunt trauma which can cause a globe rupture, rupture of RK wounds, rupture of previous ICC incisions and graft house junctions after PK. They can also cause blunt injury to the corneal endothelium. The corneal endothelial cells, because of the resultant shock, cause the swelling or edema of the cornea. However, this is temporary and it resolves. Now, repair of penetrating injury, partial thickness corneal injuries do not really require sutures. They are self-sealing, and just topical antibiotics and bandage contact lenses with observation will do the patient good. We'll show you some pictures of self-sealing corneal injuries. Now, we will go through the goals of surgical repair of full thickness corneal laceration. The goal of any corneal tear repair is to restore the integrity of the globe, to minimize current and future complications either at the time of the initial surgery or during subsequent surgical repairs. Anesthesia also, Dr. Maskati has spoken very well. Any case of corneal trauma is an emergency. Prompt repair is required to decrease the risk of endophthalmitis. 10-0 monofilament nylon on a spatulated needle is preferred. The sutures need to be short. The length of the suture should be somewhere about 1.5 to 2. The depth at which the sutures need to be taken is about 90% corneal depth. The sutures need to be equal in length on both sides of the incision, especially in perpendicular incisions, and each suture should be oriented at 90 degrees to the wound. If the sutures are very shallow, that is if they are superficial, they will result in internal wound gape. If the sutures are not equal on either side of the length, if they are asymmetric, once you tighten the suture, there will be wound override. If the suture is full thickness, it will act as a conduit for microbial invasion, and there will be a greater risk for developing endophthalmitis. All the knots that are taken need to be buried away from the visual axis to minimize the amount of scarring and vision loss. Sutures need to be equal in length on the surface in case of perpendicular wounds. However, in case of oblique wounds, I'll just show you a picture. What do we mean by oblique wounds? The lower picture is an oblique laceration, which is kind of partially self-sealing but not really self-sealing. These lacerations, the length of the suture needs to be equal on the posterior aspect and not necessarily on the anterior aspect. Otherwise, there will be a wound overlap. The perpendicular incision or the perpendicular rupture is seen in the figure above, where the sutures need to be equal in length on the surface. The suture should be tight enough only to oppose the corneal wound. They should not distort the wound too much. It is important to align the limbus first, and then you continuously bisect the remaining wound. Take the limbal sutures, or if the wound is not limbus to limbus, you suture the ends of the wound first, then you take the middle suture, and then you continuously bisect so that you have sutures that are equidistant from each other. Then whenever you have wounds which are irregular, like they are perpendicular in some portions, they are oblique in some portions, you suture the perpendicular portion first to achieve water tightness, and then you go to the oblique portions which are relatively self-sealing, so that at all times the anterior chamber is formed. Any corneal incision or any corneal tear is going to cause flattening in the region of the tear. To counter that flattening, we could take large compressive sutures on the ends of the incision so that there is relative flattening in the periphery and steepening in the center. The central sutures could be slightly shorter and just opposing to minimize the flattening that can happen due to suturing and the incision. Running sutures are normally not the ideal thing to do in case of corneal tear repair, because the length of the incision then depends on one knot. If there is infection of any portion of the corneal wound, the suture will start loosening up there, and then the integrity of the entire wound is compromised. So in case of corneal tears, especially if they are not very regular in length and appearance, it's better to go for interrupted sutures. Besides, you can keep titrating the astigmatism also depending on how much it is. Sorry. This is just simple corneal tear repair. This was a 6-year-old child who came with this corneal injury. He didn't even remember, possibly it's a knife injury. He was too quiet. He didn't even tell his parents what happened. Suddenly when he refused to open the eye, they realized that there's a problem and they went and showed the doctor. The wound appears infected. I'm just trying to freshen up the edges. He has a ruptured lens. Usually we make a paracentesis, form the anterior chamber with a sweeping movement, just move the iris and the ruptured lens matter away from the inside of the corneal wound. Form the anterior chamber either with air or with visco through the paracentesis, and then start taking the sutures. I've sutured the ends of the wound first, then the central suture, and now I'm going to take the sutures in between. I don't know whether you can see it. All the sutures are done now. Sometimes you may have a stellate wound like this, where you may need to take a purse string sutures to bring the apices together. This was a patient with firecracker injury who had this contusion injury to the corneal endothelium. The cornea is looking edematous and there are multiple cuts on the cornea. I'm trying to assess which are full thickness, which are partial thickness. But it's a very irregular tear, sometimes very difficult to close. Somehow after assessing the tears, I managed to put just 4 sutures, which were really long and they were straddling multiple cuts. But still at the end of it, didn't know whether the wound was, I was sure it's not watertight. So to get around, I put glue. I put fibrin glue and these are the sutures at the end, but I'm sure it's not watertight. There was still leakage somewhere, so I didn't want to macerate the cornea any further. Put fibrin glue because at the end of the procedure you don't even feel that you've placed anything. After putting the fibrin glue, put the BCL. And this is how he looked 2 days post surgery. The edema is resolving. The anterior chamber is well formed. And this is how he looks 3 months post surgery. In corneal scleral lacerations, it's better to oppose the limbus first, at least to secure the anatomical structures. Then you could close the corneal wound and then you close the